One of the mistakes that we make when we think about pharmaceuticals as an approach to pain is the question is, which pharmaceutical? What are the broad tools that exist in this toolkit that can help approach pain in an effective way? This is the story of surveillance capitalism. Things that we typically think about as data exhaust, just information that nobody really needed, have now become really critical to a lot of companies' bottom line. They're making money off of surveilling us. With opioids, you might not use opioids right now, but any one of us could be hit by a car tomorrow and be catapulted into chronic pain and have to live with that for the rest of our life. I hope that doesn't happen to any of us, but it could happen. And if it did, we would really hope that our doctors would be willing to give us the most effective pain treatments.
You're listening to Narcotica, a podcast giving you the straight dope about drugs and the people who use them.
Opioids are some of the best drugs ever invented. Newsflash. But that's not something you really hear from the mainstream media anymore. No, the official message is that opioids are only problematic, and even in the instances where they are prescribed by doctors, there's this baggage, this stigma, and shame attached to it. Oh, you're taking Oxycontin for your cancer or a herniated disc. Well, hurry up and get better so you can get off of these demon pills. It's better for you to suffer or destroy your gut with NSAIDs than it is to use something that, gasp, Purdue Pharma overmarketed. Of course, opioids can be addictive, risky, even deadly. Let no one downplay these realities. But they shouldn't always take a front row seat to all the benefits that opioids bring. On Narcotica, we make it a point to emphasize that even using street drugs has value, otherwise people wouldn't do them, and we can't divorce the harms of drug use from the benefits. That just isn't reality. But strictly concerning medical opioids, from morphine to heroin to fentanyl, opioids have come a long way. And we often forget that anesthesia as a practice is a pretty modern invention. Before that, needing surgery or suffering a major injury was brutal. Anyone saying we need to get rid of opioids entirely wants to return us to a time before germ theory or antibiotics were a thing and routine infections killed people. And no, recognizing that does not make you a big pharma shill, in spite of drug companies that have exploited and yes, in some cases, overprescribed these substances. But that's a critique of capitalism, not chemicals that happen to mercifully act on our opioid receptors. Of course, no one really outright says that we need to ban all opioids. That's sort of a straw man argument, I admit. If you ask people at most anti-opioid organizations, they will be quick to say that banning all opioids is wrong. As long as they are used in narrow circumstances, they're fine. But in effect, that's what we are doing, banning them. Prescriptions of opioids have dropped significantly in the past decade, falling by over 51% over 11 years, from 260 million in 2012 to 125 million in 2023. That hasn't resulted in a significant drop in overdose deaths. Instead, the current climate and attacks from the DEA has left many doctors now afraid to prescribe these drugs even when appropriate. And the rash of stigma against people who use opioids, licit or illicit, has not done anything to actually stop drug use. But these policies and attitudes do have an impact. Who has been harmed the most? Patients that need them. I'm Troy Farah, and you're listening to Narcotica. Our guest today is Liz Chiarello, an associate professor of sociology at St. Louis University, where she conducts research at the intersection of healthcare and law. Her research centers on how cultural forces such as law, politics, and organizational policy influence decision-making in healthcare and the criminal legal system. She is the author of the recent book, Policing Patients, Treatment and Surveillance on the Front Lines of the Opioid Crisis. Before we get to that, we have a short PSA, which is thank you for listening to Narcotica. It takes a lot of time and effort to make each episode, which is clear by the fact that we produce a lot less lately. But we are still going strong and bringing you independent drug policy journalism. We are listener-funded, like NPR and other podcasts, so a deep thank you to our patrons who make this show possible. You can join them at patreon.com/narcotica. We also have a shop with some merch. You can find that and much more, including all of our previous episodes at narcocast.com. Recently, we've uploaded all of our episodes to YouTube, so if you want to listen and subscribe there, go ahead and search for us. We're going to try to monetize those videos, but doubt it will work because, frankly, not being anti-drug and the amount that we swear on this show, it's just not the sort of thing that Alphabet, Google, whatever likes to allow advertising on. So the best way to support us is still Patreon. And we'll be bringing new perks soon, so thanks again for listening. And now, onto the show. Again, our guest is Liz Chiarello, author of Policing Patients, Treatment and Surveillance on the Front Lines of the Opioid Crisis. Liz, welcome to the show.
Thank you so much for having me.
So let's start with your book. It's titled Policing Patients, Treatment and Surveillance on the Front Lines of the Opioid Crisis, which is out now from Princeton University Press. It's an extensive book. It's very thorough and detailed. It features 337 interviews over a decade. Congratulations on this project, because it seems like you put a lot of work into it. Have things changed much since it came out?
Well, thank you for saying that. And, it came out in September. And so I think in terms of professional practice, most things have not changed. But I do think that the biggest thing that has changed is the new presidential administration, which I think has signaled it's going to be very unfriendly to harm reduction. I remember that President Biden got a lot of kudos in 2022 for supporting harm reduction in his State of the Union address. And of course, I think no presidential administration has ever been fully on board with harm reduction, but we seem to be moving in the right direction. And now I think we're poised to take several steps backward, and that those changes are going to trickle down from the administration all the way into practice and into patient care.
Yeah. We'll get into the politics and stuff as well, because it is such a changing landscape and everything. But I really do appreciate your book because, a lot of patients that need opioids are treated like criminals before they've even done anything wrong, or a lot of them are completely innocent. Opioids have been so demonized in our society, and it's just sometimes really hard to break through and tell people the truth of what's happening. And there's this real dominant narrative that, big pharma is responsible for this whole thing. There's so many documentaries and books about this, but it's just not the full picture. And it's very frustrating sometimes when you're trying to explain this to people. So could we briefly go over, why Purdue and Johnson & Johnson and all these other companies, they played a role in the beginning, sure, but I don't think they deserve as much credit as they get sometimes for this crisis. And especially not now, where we're at in the wave of the fourth wave, as it's sometimes called.
Absolutely. I think, they were a necessary but not sufficient factor in helping to shape the crisis. And as you mentioned, there have been a lot of books, there have been a lot of narratives. I think the kind of taken for granted cultural narrative about the opioid crisis is that an evil drug company or a set of evil drug companies peddled an addictive substance to the American public and refused to stop when that drug proved deadly. And it's a really compelling narrative. It's something that has us all very concerned, and it leads into a lot of critiques of the healthcare system and critiques of big pharma, many of which I think are warranted. But in terms of thinking about this specific crisis that we care about as individuals, because so many people have been affected by this crisis, trying to stop the crisis by telling ourselves that story and then using it to lead us to specific kinds of solutions hasn't really gotten us very far. And that's why in the book, I really emphasize putting the crisis in context, putting it in a larger historical context of the last 100 years of drug policy, but also thinking about the pain management movement and the hospice movement before it. And so what was happening in this country that created the need for something like OxyContin? And then what has happened to those people since? And I think also the other big problem with that narrative is it's a supply side story. The argument is, people use drugs because drugs are there. But drugs have been there for a long time, and a lot of people don't use drugs. Or people use drugs and don't use them chaotically. And so we have to actually look at the groups of people who are using drugs and ask the demand side question, which is, why are they using drugs? And why are they using drugs in a way that is harmful to them? Like, what are the bigger factors that are shaping that? Certainly drugs have to be available for that to happen, but it's a much bigger story, and one that I think we haven't fully told.
Yeah, I agree. That's really frustrating that the whole focus is on supply side and not demand. Just because, access to healthcare and access to economic mobility, like being able to have a house or a job, those sorts of things play way more of a factor into addiction, I think, than the drugs themselves. And if opioids weren't available, people would probably rely on something else, especially since, you have to explain to people sometimes there's a difference between illicit fentanyl and like regular fentanyl. And I've heard so many stories of people who go to the hospital for a legitimate reason and they refuse to take fentanyl because they've heard that this is this demonic drug. And it's just a lot of misinformation coming from all sides on this, and the solutions being proposed are the same old thing, which is just more cops and like, let's secure the border and that kind of thing. But then you have these chronic pain patients, and they are people that really do rely on opioids, but now they're treated so harshly, it seems. Can we talk about some of the ways that patients are being policed, especially with the Prescription Drug Monitoring Program, or the PDMP, and why it matters?
Yes, absolutely. So this was something that I kind of happened upon. Frankly, I happened upon this whole project. My world was reproductive health, and I started doing research on pharmacists and pharmacy ethics in relation to emergency contraception. And as I started interviewing pharmacists about their decisions about emergency contraception, they wanted to talk to me about opioids. And so I got a lot of data on this back in 2009, before the opioid crisis had really fully taken off or was really fully on the national agenda. And then as I ventured more deeply into this study, I learned a lot about the Prescription Drug Monitoring Program. And I thought, well, this is a really fascinating technology. And most people don't even realize that the Prescription Drug Monitoring Program exists. And so it might be worth talking a little bit about what these technologies are and what they do. So PDMPs are two-tiered surveillance technologies. They're essentially aggregated pharmacy dispensing data. So you have a prescription for oxycodone and you go to the pharmacy, they give you your pills, and then they also send information about that prescription to a central system that's run somewhere in the state apparatus. Sometimes it's the Board of Pharmacy or the Department of Justice or the Department of Consumer Affairs. But that state agency is in a relationship with a private company, most often Bamboo Health, and they aggregate the information that comes from all of these prescriptions in the state. And then they feed the information back to physicians and pharmacists who can use it to make decisions about prescribing and dispensing medication. But they feed the same information to law enforcement, who can use it to go after physicians and pharmacists for criminal or administrative violations. And so that's why I call it a two-tiered surveillance technology. I also talk about it as a Trojan horse technology. And the reason I call it that is really twofold. One is that the PDMP was a gift, much like the Trojan horse was a gift from the Greeks to the Trojans. The PDMP was a gift from law enforcement to healthcare. By which I mean PDMPs were largely created and expanded through Department of Justice grants that have been used in most states. And the other piece of it is that PDMPs were originally designed for law enforcement. They've only been used in healthcare over the last 15 to 20 years or so. And so what I show in my research is that as the PDMP has made its way into healthcare, the logics that are attached to it, or ways of making sense of the world and ways of acting on the world that are attached to it, help to reshape the way that physicians and pharmacists behave. So they start to act more like cops, and they start to take for granted that policing patients is part of their job.
Yeah, I can totally see, like, on the surface, like, it seems smart to track these opioids and everything, but the cops having access to it and starting busting these pill mills and things has a chilling effect on doctors. And it seems like it's harder to get opioids than ever prescribed. It depends on where you are and your doctor, of course, and also the condition that they're being prescribed for. But way too often I hear people, getting ibuprofen for surgery and that kind of thing. And like, I think a lot of patients are also afraid to go to the doctor and express that they have physical pain because they don't want to be seen as, quote, drug seeking. This has been a topic that's been going on for a while. And the reason why I wanted to invite you on is because, like, this is a recurring thing. Like, these patients really feel like they don't have a voice when they express the fact that they are cut off or scrutinized, stigmatized against. People just like dismiss them and just be like, well, these are opioids. They're demonic. They're highly addictive. They can't be used safely, which of course is false. it doesn't seem like things are changing much. Would you agree? Like, are we moving in a better direction where we're being able to prescribe these drugs more, or are patients kind of being left in the lurch?
Yeah, I think it's a really complicated question. And one of the things that I want to point to in what you were just talking about is people with pain, with chronic pain, and people with substance use disorders have been pitted against each other in a zero-sum fight over opioids. And so the assumption in the early 2000s, certainly advocated for by Purdue Pharma and others, was as long as you were prescribing opioids for pain, people wouldn't get addicted to them and they would be fine, and you could raise the dose as much as you wanted and you would have no issue at all. And that served their bottom line, I think, more than it actually served patient health. But that was the narrative. And now the narrative is opioids are good for almost no one. They cause more problems than they solve, and we should really reduce prescribing, and that is going to benefit patients. But that's not true either. You know, there are a lot of people who are being hurt by either being tapered off of their medications or being cut off of their medications. People who you were saying, you know, who get surgery and then aren't having their pain adequately treated after surgery. So what we really need to do is right size opioid prescribing. You know, we've gone from this very liberal moment where, you know, it's like an opioid for everyone. Though of course not everyone. There were always race, class, and gender dynamics that shaped who got access to opioids, to this moment where the story is opioids for no one. But really, opioids are a really powerful tool in the medical toolkit, and they have an appropriate use. And so we need to make sure that they're being used for the right patient, for the right condition, at the right time. And that's the space that we can't quite seem to find. But I think in terms of people with substance use disorders and people with chronic pain, there are these really powerful narratives around who is the deserving patient. You know, and the argument has been, well, people with pain are legitimate and they are the deserving patient, and people with substance use disorders are not legitimate. You know, maybe like they can get buprenorphine, but of course they don't, quote unquote, deserve access to other kinds of opioids. But that picture gets really complicated when we talk about fentanyl and some of these other dangerous drugs that are really doing a lot of harm. And so I think if we look at those two groups as groups with shared fates, who both need to benefit from the healthcare system, we come up with different solutions than the solutions we have now that tend to pit one group against the other.
Yeah, I unfortunately see that far too often with some chronic pain patients who really resent illicit fentanyl users. You know, a lot of them unhoused, maybe having a mental health episode or something like that on the street, and like that's a very visible sign of addiction that isn't really representative of what addiction even looks like. I think that's a very outlier kind of thing, but there's a lot of resentment from the chronic pain patient towards those people because they see that they're giving everything a bad name and like kind of tainting the way that opioids are used. And I just wish that there was more of solidarity between the groups, because they have the same goal, which is, you know, being treated like a human being and getting access to healthcare in the end. But there's also this other narrative, I think, that, you know, patients that use opioids long term, like that's never appropriate. And that people who do use opioids long term and are, you know, trying to advocate for themselves and say, no, I do need this drug, they are often accused of being lying or addicted or something like that. And this concept of hyperalgesia is brought up a lot, which is this sort of extra sensitivity to pain after using opioids long term, which seems to be kind of rare. But like, can we unpack that a little bit? Like, do chronic pain patients have a point that they should be allowed to use opioids long term?
Right. Okay. So just remember, I'm not that kind of doctor, right? Like I'm a PhD and not a medical doctor. But I think we can think about this in terms of whose perspective matters. Whose perspective is important. And this is true when we think about healthcare at large. You and I can talk about it in relation to opioids, but it's really a discussion that's been going on for decades in medicine, which is the tension between a paternalistic approach to medicine, which is basically doctor knows best, and a patient-centered approach to medicine that values patient autonomy and patient voice. And those two approaches approaches really tend to bump right up against each other. And I think with hyperalgesia, I mean, the data that I've shown shows that it's a thing that happens in rats. You know, rats are certainly more sensitive to pain when they're on higher doses of opioids. And there's some evidence to show that it's something that happens in humans, though it might be quite rare. But basically, I think those narratives tend to tell patients that they don't know their own bodies. And that to me is really troubling, because saying to the patient, yes, I'm tapering you down off of this medication, and you're going through withdrawal or you're in a lot of pain because I'm taking you off of the medication. But the fact that you were on the medication is what was actually causing you pain. And the patient says, no, I was well managed on my medication until you started tapering me. Like I wasn't in pain until you started tapering me. And the doctor saying, no, you know, like I'm the one who actually knows what's best for you. That to me is really troubling and problematic. But I also think that wouldn't be at such a great tension if we weren't in such a punitive moment when it comes to opioids. Because picture for a minute that we're in a world where patient care is really at the center of medicine, and we want to make sure that patients are doing well, and that their pain is managed and that they're really well taken care of. But we're concerned about hyperalgesia, and we think perhaps, you know, this is a medication that's causing them pain, and we want to find out. Well, then what we would do, what the doctor would do, not me, not you or me, but a doctor would do, is they would taper the patient down slightly, and they would see how the patient did. And if the patient did really well, then they would say, maybe we'll taper you a little more and see how it goes. But if they tapered the patient down a little bit and the patient said, this is really awful for me, I was so much better on my higher dose, the doctor would say, okay, we'll put you back on your higher dose. But that's not where doctors are right now. Right now, I think doctors feel, partly they feel threatened, but also partly the norms around opioids have shifted. And so they, you know, once they've tapered somebody down, they want to keep tapering them down. They're pretty unwilling to raise the dose after they've tapered somebody, no matter what the patient says. And so as a patient, you know, I wouldn't be open to tapering if I knew that there was no going back. And so I think that this punitive moment really creates a lot of conflict between doctors and patients when a more patient-centered, medical-centered approach could allow doctors and patients a lot of different options and could help us figure out things like this. You know, like, are the opioids causing more pain? Well, we could test that patient by patient.
Yeah, I think that's something that's a huge hazard from policing patients, is it's seeing everything in sort of this binary of like, you're doing well or you're not, instead of being like, let's try a little bit and see how you respond, and trusting the patient about what they're saying about themselves. It seems like, I mean, we could talk about this a little bit. It's a little wonky, but the CDC in 2016 made these recommendations on opioid prescribing. It kind of got taken by law, and then a lot of, it's like, I think that there was pushback on this and all this kind of back and forth on it, but it's just weird, like, you know, that they kind of made these limits that it's like a one-size-fits-all for patients. You can correct me if I'm wrong on this, but it doesn't seem like there's been a very major reckoning on that. And if there has been, like, it seems like there's also just more and more tools of surveilling patients that are being introduced, especially with AI and just more algorithm stuff. And that's playing a bigger and bigger role in who gets opioids and who doesn't.
Yeah, so the CDC guidelines, the 2016 CDC guidelines were a revelation, but in ways that I think a lot of people find really problematic. Because they were really designed for general practitioners, and they were really designed for opioid naive patients, but they got applied really broadly, and they were almost immediately taken as if they were law by insurance companies and hospitals and clinics and doctors. But guidelines are guidelines. You know, they were setting some norms and some boundaries, and they did recommend a lot of things that I think of as policing patients. You know, the urine drug screening, the PDMP checks, the pain contracts. These aren't things that we do in other areas of medicine. And people might push back and say, well, of course we do urine testing, and we do for pregnancy and for diabetes care and things like that. But they're used in a really different way when it comes to opioids. They're used to deny care more than they're used to venture more deeply into the healthcare system, which is what happens with most urine drug screens. But anyway, so the CDC guidelines recommended a lot of these approaches, but notably, they also set limits around how many morphine milligram equivalents people could be on. Which, of course, I know y'all have talked about this on the podcast before. So, but this is just a way of standardizing opioids across different medications, is to basically standardize them off of morphine. But they said, that you shouldn't be prescribing above 90 morphine milligram equivalents. And ideally, you wouldn't even prescribe above 50 morphine milligram equivalents. Well, the people that those guidelines left in the dust are the people who started to receive opioids during that really liberal moment of opioid prescribing, where the prevailing logic was that you could prescribe as many, as high of a volume as you wanted and have no repercussions for people in pain. So some of those people are on 250, 300, 500 morphine milligram equivalents. And doctors, of course, having those guidelines in hand, are not at all comfortable prescribing such a high dose for those legacy patients. And so their move has been to taper those patients off, or taper them down. And I think that's done a lot of harm to patients. There are new CDC guidelines that came out that tried to remedy what had happened with the 2016 guidelines. But I think by the time those things got institutionalized, like once you weave it into your policy and your practice, it's really hard to then tease it back apart. And so I think the 2016 guidelines are continuing to have an outsized effect on medical practice today.
Yeah. That's definitely what I've seen is, once, like you said, once it's institutionalized, it's there, and like people want to go with the more strict guidelines, and it's getting weirder too. I think Maya Solovitz had a cover story in Wired about how patients can be denied opioids from an algorithm. It's not even doctors that are necessarily denying care anymore. It's algorithms and AI, and that just gets into these bigger and thornier questions. I appreciate that on other interviews you've done about your book. And your research, that this stuff exacerbates existing disparities. So, people of color, people who are poor, like those people are going to get denied care more often than, affluent white people.
Yes. Well, and the technology is really complicated, in my view, because the PDMP, of course, is a black box algorithm. We don't really know what goes into it. And we don't exactly know what comes out of it, right? And PDMPs have changed over time. So the original PDMPs essentially looked like an Excel spreadsheet. So if I'm the doctor and I'm looking at the PDMP, well, first of all, I have to log out of my system and I have to log into this other system. And then it's going to show me, you're my patient. It's going to show me, all the doctors you've gone to and the medications you've gotten and what dose they've been and when you got them and what pharmacy you went to. Well, I have 10 minutes with you if I'm lucky, 12 minutes, and that's a lot of information to try to process. So then I'm looking at the spreadsheet and I'm like, is that a lot? Are those a lot of doctors? What's going on here? And so the PDMP has become more algorithmically sophisticated over time. So it went from that spreadsheet to something that created like charts and graphs. And so you could see, how many doctors was it and, what is the volume, to what it has now, which is a NARCS score that is supposed to indicate the likelihood of overdose. But we don't know exactly what goes into the NARCS score. We can assume that it's a lot of the red flags that the DEA has talked about as being problematic, but we don't exactly know. And Bamboo doesn't have to tell us because they're a private company, and so they have their trade secrets, and what's happening for the PDMP is part of that. And so this problem of algorithmic inequality and then and bias that you're raising is really important. And there's a great book by Virginia Eubanks called Automating Inequality that talks about all of these different social services that are now using algorithms to decide who gets access to resources and who doesn't. And that's in housing, it's in a couple of other areas. And so we're seeing that too with healthcare is, who's getting access to care and who's being denied is being grounded in an algorithm that we don't even know what the recipe is to create that algorithm. And I think that the opaqueness of it is a big part of the problem as well.
Yeah, I agree. I think, in my opinion, that shouldn't be legal. Like, you shouldn't be allowed to have proprietary information that's being used to deny care to people. But that gets into the whole aspect of big pharma and money and the healthcare industry. And how do you untangle that? I mean, it's a huge, huge thing.
That's a whole other podcast.
Yeah. It also seems like we just need better regulation of the regulators in a way. Like, instead of having these sort of one-size-fits-all things for everybody, just being a little bit more thoughtful about how we use these programs. Because I think you've said this before, the PDMP is just a tool. It can be used effectively or ineffectively. And unfortunately, it seems like it's used ineffectively a lot.
Well, it's interesting. It is a tool, but it's a specific kind of tool. So, when I talk to doctors and I talk to pharmacists, in general, they really like the PDMP. And I think they really like it because it gives them information they didn't have before this technology came around. Pharmacists in particular, because of course your pharmacist doesn't have access to your medical record. And so all they're seeing is your prescription and then whatever other prescriptions are in their system. But they don't, what they know about you, they get from talking to you. But they're not like a doctor who can look at the electronic health record and then see what's going on. And even if you're a doctor, if your other doctors are using a different system, they don't necessarily have access to your electronic health record. And so there are a lot of blind spots in medicine and in pharmacy. What the PDMP does is it gathers all of your prescription data. Well, your prescription data for controlled substances, and it puts it in the same place. And so then you can see all of that information, and ideally it will help you make a better decision. And so when doctors and pharmacists say they like it, I mean, I believe them. I think it really does help to have more information about the patient rather than less. The problem is that the data that's in the PDMP isn't protected by things like HIPAA. It lacks the privacy protections that we see for your electronic health record. And so having the information is great. Should they have the information through a database that was designed for law enforcement that has made its way into healthcare, or should that information be in the electronic health record and everyone should have access to a single electronic health record? I certainly think if we're trying to do good medicine, the latter is the better practice because there are some serious costs to law enforcement having access to these kinds of data.
So I guess the big elephant in the room is, the Trump administration and Robert F. Kennedy Jr. being in charge of Health and Human Services. Like, what are your thoughts on the way that public health is being managed in this country right now and how that will translate specifically to chronic pain patients and people who need opioids?
Yeah, I think we're looking at a really rough next 4 years when it comes to public health. The current administration seems very interested in dismantling critical aspects of the federal government. And I think that the cuts that they're imposing are going to have a really negative effect on access to care for both chronic pain patients and for people with substance use disorders. So, for example, last month, the administration announced plans to cut 80,000 employees from the Veterans Administration that provides healthcare to millions of veterans. And that, of course, was a really shocking move because I think culturally we tend to think of veterans as very deserving patients, like very deserving of access to care. But it's not just those services that are at risk. It's also the expertise that has been housed in all of these agencies. As they're cutting the agencies and getting rid of the workers, they're losing a lot of institutional knowledge in the process. So I think it's going to have an impact on care, it's going to have an impact on expertise, and then of course it's also going to have an impact on research. A lot of the innovations around pain treatment and harm reduction are supported by federal grants. And like my research is funded by the National Science Foundation. So how are we going to know what works if we can't even study it? And I think these attacks on science writ large are likely to create harms that reverberate throughout the healthcare system. I don't think that means all hope is lost. I think what happens is, people are going to have to pivot and they're going to have to find ways to do good, even when the system is not set up for them to do that. But I'll tell you, I've always found harm reductionists really inspiring because people who do harm reduction have been doing this work at great risk to their own lives and liberty. The people who've handed out syringes when it wasn't legal, the people who have made sure that people had access to Narcan, those are pioneers in the field, and they have followed their own moral compass, regardless of what the law or the healthcare system said to them. And I think we're going to have to take a page out of their book and think about how do we do good work at a time when science is being threatened.
Yeah, absolutely. And I appreciate that a lot because it is a chaotic time, but despair isn't necessarily the right approach. I don't think we should just give up, right? So, and there are a lot of strategies in harm reduction that I think are applicable here.
And the other piece that I think is really important, so we know this, so part of my background is in studies of social movements. And one of the things that social movement scholars say is people are more likely to mobilize around the threat of having something taken away than around the possibility of gaining access to something new. And particularly with harm reduction, we've had a moment where a lot of harm reduction has come out of the shadows and has been kind of legitimized at an institutional level. And the idea of taking that away and forcing it back underground, I think there are many people who will not stand for that. And that's true in a lot of other areas too. I mean, it's true with abortion, it's true with a lot of other kinds of care. And so we're in a moment of threat, but we're also in a moment where we're very much armed with knowledge and with capacity and with networks. And I think that could really make all the difference.
I kind of wanted to talk to you about gabapentin and other non-opioids and how these drugs seem to be being pushed more for pain, even though I've heard so many stories that they're just not as effective. They have weird side effects sometimes. And that, opioids are just such an amazing drug that they work really well, that they have side effects and they can be addictive, but like those things can be managed. So what are your thoughts on some of these other medications that are being pushed on patients?
Yeah, first of all, I don't think everybody who's currently on an opioid should be switched over to gabapentin. I think that would be a mistake. I also don't think everybody who's currently on an opioid for pain should be switched over to buprenorphine or Suboxone, which also seems to be one of the big moves. I think that patients know their bodies. And most people who have chronic pain have been on what sociologists call like a pain pilgrimage, which means you've gone from doctor to doctor to doctor. You start with the pain and then you're like, what's going on? You go to a bunch of different doctors. You finally find the thing that works for you. And when you find the thing that works for you, you want to hold on to that for dear life. And when doctors say, oh, we're going to try you on something different, or the insurance company says, we're not going to cover that, it's really scary because as a patient, you're facing down being catapulted back into pain. You're going from being functional to the possibility of living a really hampered life. And so I think I am sure that gabapentin has its place in medical prescribing. I don't think it's right for everybody. And so I think we should take patients seriously when they say that the thing that they're on is working for them. And we also need to recognize that I think there's an over focus on pharmaceutical approaches to pain treatment. And we need to think more expansively about approaches to pain treatment that work. Within the medical field, there are drugs and there's surgery, which often has really negative outcomes. And then there are a number of different interventions. So things like cortisone shots or stem, all kinds of different approaches. But there are a lot of other ways of treating pain that fall outside of mainstream medicine. Certainly, physical therapy can be effective for some people, but even beyond that, some people respond well to massage, and some people respond well to yoga or to rolfing. Like there are all kinds of things that can work for people. So I think one of the mistakes that we make when we think about pharmaceuticals as an approach to pain is the question is, which pharmaceutical, not, what are the tools, what are the broad tools that exist in this toolkit that can help approach pain in an effective way. And I can imagine an opioid plus something could be really effective, or gabapentin plus something could be really effective. But unfortunately, the way that medicine is set up, the boundaries are so strict that any kind of connection to any sorts of alternative treatments largely doesn't exist. And so I don't know that that we're treating pain as effectively as we can. And the idea that like we just go from one pharmaceutical to a different pharmaceutical, I think is really short-sighted. And we need to be thinking more comprehensively about the causes of pain and pain treatments.
Yeah, I wanted to talk a little more about how the surveillance of patients with opioids it's really not something you see anywhere else in medicine, except for maybe addiction treatment. Like methadone is the most overregulated medication in the country. And it has been that way for decades, although that's slowly changing. But it seems like there's a possibility of sort of like mission creep, for lack of a better term, where, okay, we're surveilling these patients because of opioids and the risks that they have, but now it seems like it's being expanded to things, especially abortion drugs. Those have been banned in some places already. They've been labeled as Schedule I drugs in some places, which is just insanity to me. We can talk about that a little bit if you want, just because the whole scheduling system doesn't make sense, but especially applying it to a drug like misoprostol or something like that, or have more uses than just abortion, obviously. Are you seeing that, like these tools for surveilling patients started with opioids and is now kind of expanding to other medications and other parts of healthcare?
Yes, absolutely. And I think a lot of times what happens is we test surveillance technology on the most vulnerable groups, often on groups that are vulnerable and groups that are small, and often don't have a large political voice or a strong political voice. And then you do see the function creep or the mission creep. The technology, once it's created, suddenly you can use it for all kinds of different purposes. And this is the story, for example, of surveillance capitalism. Things that we typically think about as data, or were for a long time thought about as data exhaust, just information that nobody really needed, have now become really critical to a lot of companies' bottom line. They're making money off of surveilling us. And we allow ourselves to be surveilled because we really like to be in touch with our high school friends. And, we really like to post our pithy comments on the internet. And so I think surveillance has become such a normative part of everyday life that we don't necessarily think about the consequences of being surveilled. But what happens is once you create an apparatus like the PDMP, a lot of other drugs suddenly start to look surveillable. And so you mentioned the abortion drugs, and that's really critical because what they've done, like in Louisiana, for example, I guess a lot of people who listen to this podcast know about controlled substances and about federal scheduling. And so you might know that marijuana, for example, is a Schedule I drug. It's considered to have no medical utility at the federal level. And other drugs, I think, OxyContin for a long time was a Schedule III, now it's a Schedule II, or Vicodin was a Schedule III, and now it's a Schedule II. So anyway, things move along this schedule, but they're supposed to be scheduled based on medical utility and likelihood of addiction. And abortion drugs are not addictive, but some people consider them harmful. And so what has happened, like in Louisiana, for example, is they have turned it into a controlled substance. Well, PDMPs track controlled substances. And so all you have to do then is reframe a drug as a controlled substance. And then a lot of people have access to who's using those medications. And so you might think to yourself, well, I don't use opioids and I don't plan on having an abortion. But once these systems get set up, we should all be concerned about what data ends up making their way into the system. And, with opioids, you might not use opioids right now, but any one of us could be hit by a car tomorrow and be catapulted into chronic pain, and have to live with that for the rest of our lives. I mean, I hope that doesn't happen to any of us, but it could happen. And if it did, we would really hope that our doctors would be willing to give us the most effective pain treatments. And I think this kind of system really gets in the way of that possibility.
Yeah. Are you seeing that though more? Are you seeing abortion drugs specifically being surveilled more? I've heard of people saying that they are being sold on the street more, like street corners, not just like mailing them to people online, which I think the doctors that mail that stuff are heroes. Like, and I'm glad that they are putting some risk out there by doing that, but making sure those patients have access to that is critical. But I've heard about these drugs being sold like you would see a dime bag being sold now.
I mean, that is so interesting. I have not heard that, but I think you are also, I know that you talk a lot with people who use drugs and have, you probably have a closer connection to people who are seeing that than I do. The doctors who are mailing them, actually, they shouldn't be at risk because legally they're really not doing anything wrong. I think there are a lot of efforts to construct them as doing something that's illegal, but in fact, the law is pretty clear that because they're doing it through telemedicine, and so if they're seeing the doctor in the other state, that state's laws apply. And there's a new book that just came out, I think it's called After Dobbs, that shows that actually in states like mine, Missouri, the abortion rates for women living in Missouri has gone up after Dobbs. Partly because people are getting easier access through telemedicine. And so, all these efforts to stop people from getting access to care are actually backfiring. I haven't seen them on the street as a street drug. And it's like, I don't know what you would get out of snorting misoprostol, right? I think it's probably being sold the same way that people sell buprenorphine, which is basically like, I've gotten a hold of this, and now through this kind of mutual aid mechanism, I'm going to make sure that you also have access to it so that you're not going through the pain of withdrawal, and so that you can see if this is a drug that works for you. I imagine that abortion drugs are, if that's what's happening, then they're operating in a similar way.
Yeah, definitely not recreational, but just when there are barriers to healthcare access, people will find a way around them, even if it's an underground market. So, and it has just been a rumor that I've heard. I would like to investigate it more myself. I just haven't had time. So,
I mean, one of the things that we see in the opioid realm is, people think they're buying heroin and they're actually buying fentanyl, and that has a very different that can really do a lot of harm if you're not accustomed to fentanyl. It can increase the risk of overdose. But imagine you think that you've taken a drug to end a pregnancy, and it's not what it says it is, and then you're still pregnant, and you still have to deal with that. I mean, that's really troubling. And
yeah.
so I think that's why we want regulated drugs to work. We want our system, the one that's institutionalized and regulated, to operate as it says it's supposed to be operating. But too often that's not what works. Politics really get in the way of patient care.
Absolutely. And I think that's one of the things about when we're surveilling other medications like these abortion drugs, like it does create more risk than it prevents, right? Like some abortion drugs do carry risks. They're very rare. They're very manageable. And ProPublica did a bunch of stories on this, like all these people that took these drugs. And when we report on this sort of stuff, like you got to be very careful, like explaining the risks, but not making it scary or whatever. And a lot of these patients that died on these abortion drugs, those deaths were completely unnecessary. They were ruled by medical boards that this would not have happened if it wasn't for the abortion bans in states like Texas and Georgia. I think that's why I love talking about drugs, is because it does kind of connect to all these bigger, broader social issues. It's just really frustrating that like maybe people can see that it's fine, we're just surveilling the opioid patients, but then it ripples out and it becomes this bigger and bigger problem that becomes harder to untangle and to understand.
Yes. And I think at the heart of all of this is bodily autonomy. I think we all
Yes.
want bodily autonomy. And And whether we're talking about abortion or we're talking about opioids or we're talking about gender affirming care, or we're talking about immigrant care, all of these different areas that are under threat, I think fundamentally, patients want and deserve bodily autonomy. And doctors and pharmacists have taken an oath in which they've said that they will put their patients' needs above everything else. And unfortunately, there's so many other factors that limit their ability to do that. But I think fundamentally, doctors and patients' interests are aligned. And patients across these different areas, their interests are also aligned.
Absolutely. I think that's just a good reminder that like the bodily autonomy thing is just so critical. Like that's what it comes down to at the end of the day for so many of these issues. That was all my questions. Was there anything else in this topic you think people should know about or anything we might have missed in this conversation?
Yeah, there are a few things that I think are worth pointing out. So first of all, I think people really need to understand how medical norms have changed in relation to opioids, because I think most people think that if something were to happen to them and they were seeking pain treatment, that they would be cared for, and they don't necessarily know all of these changes that you and I are both really familiar with. And so I'm really glad we're having this conversation. Second, I think people really need to know how much they're being surveilled by private companies like the one that runs the prescription drug monitoring program. Because one of the prevailing ideas that people have is like, I don't care if I'm being monitored if I'm not doing anything wrong. And I think one of the things we know is that what counts as wrong can change depending on who's in charge, depending on how problems are constructed. And so you might not be doing anything wrong now, but perhaps having surveillance technologies that allow all kinds of people, but particularly law enforcement, insight into your medical decisions is not ideal. And then finally, one of the things I talk about in the book, a lot of times people ask me about solutions. And I argue that the best solutions for dealing with the overdose crisis that would also help us get out of a lot of other crises that we're in the middle of involve harm reduction, treatment, and prevention. And that it's expensive and it's complicated, but we have to do all three of those things at the same time. And when I say prevention, I am not talking about cops in schools and the DARE program. And I'm not talking about educating teenagers about the dangers of drugs. I am talking about the things that ensure that people get to live a good life. And so those are things like being free from violence, being free from harm, having housing, having well-paying jobs, having access to healthcare, good quality healthcare, living without threat. And we never fully live without threat, but I do think that we can take care of people's fundamental basic needs in a way that is effective and that works for all of us. And when we actually intervene into crises by focusing on helping people live a good life, we can solve a lot of problems at the same time, instead of putting our blinders on and saying, oh my gosh, we have a housing crisis. Oh no, a mental health crisis. Oh my goodness, it seems like we have an opioid crisis. Well, we have a chronic pain crisis. All of these crises are related to each other. And if we get the fundamentals right, we can really work our way out of these problems effectively and humanely.
Absolutely. Thank you for that. Because I did neglect to ask you about solutions, and I was just thinking, I guess we're just stuck like this, but we're not. And that's such a good reminder. Well, thank you for coming on the show. Where can people find you online?
They can find me on my website, lizchiarello.com. They can find me on Blue Sky. And where else can they can still find me on Twitter. I'm hardly ever there, but technically I'm still on Twitter. But those are all good ways to reach me.
Yep, and your book is out, Policing Patients, Treatment and Surveillance on the Front Lines of the Opioid Crisis. Liz, thank you so much for coming on the show.
Thank you. It's my pleasure.
Thanks for listening to Narcotica, an independent production by Narco Media. Co-hosted and co-produced by Zachary Siegel, Troy Farah, Christopher Maraff, and Aaron Ferguson. I'm your co-producer, Aaron Ferguson. If you like the show, you can find out more at narcocast.com and support us by joining our Patreon. Just go to patreon.com/narcotica. We are excited to announce that a portion of the proceeds from the show will now go toward the Urban Survivors Union. which is the National Drug Users Union, a group of directly impacted advocates for drug user health in America. This is the way social change happens from the ground up, and we are so excited to support this group that is doing such important work to fight stigma against people who use drugs. If you're a patron, you also get free stickers which are personally mailed to you. You can also request a shout out on the show. And now patrons can even get 30% off of merch in our new store, which is at narcocast.myshopify.com. We have t-shirts and coffee mugs, one that says "There are drugs in here," which is awesome. More stuff will be added soon. As always, we are so grateful to the folks that make this show possible. A little goes a long way, so thanks for making Narcotica happen. We're ad-free and we want to keep it that way. If Patreon just isn't for you, that's fine. You can help us out by spreading the word. Tell all your friends about the podcast, advocating for social justice and abolishing the drug war. You can also rate us wherever you get your podcasts. Our theme music is by Glassboy, and Jenny Shea is the voice of Narcotica. Additional music is by myself, alias Nomad1, drug-using producer. Well, I guess that's all. I hope you guys have a great rest of your day. Until next time.